Welcome, everyone, to our Developing a Sustainable Plan for CHW's kickoff meeting. It's a pleasure to see many of you here, many of you whom we know, and some unfamiliar names as well. My name is Ann Yukundi. I'm the Executive Director with the Minnesota Community Health Worker Alliance. We gather today here in partnership with the Minnesota Department of Health, community health workers, payers, and community stakeholders to build a sustainable infrastructure that meets the diverse needs of Minnesota's communities. Why does this work matter? A strong, sustainable CHW infrastructure ensures that CHWs have the support, the funding, and recognition needed to continue building bridges and bridging gaps in health equity. By updating our logic model, our roadmap for how to get there, we'll craft clear objectives, strategies, and specific activities that enable this vision, this shared vision. Through specifically stakeholder engagement and work groups, we aim to review and refine the logic model by May 2025. So this year, exciting work ahead. We'll develop stakeholder work groups, and you'll learn more about that work, formalizing charters, memberships, and schedules, as well as produce a tangible product. Our big product is a comprehensive sustainable plan for Minnesota by June 30th, 2025. So lots of wonderful work. We have all the right partners here on the call, and I'm very pleased that you're all here to join us for this work on improving health in Minnesota. So we also want to acknowledge before kicking off that the land on which we live and work is the ancestral and current homeland of Indigenous peoples who have stewarded it for centuries. But we believe at the Alliance that a land acknowledgement is not enough. It's merely a starting point. I challenge all of us to ask ourselves, how do we take meaningful action to support Indigenous communities? Some specific examples may include donating time or money to Indigenous organizations, supporting Indigenous-led grassroots movements and campaigns, and encouraging others to do so. And most importantly, commit to returning land. Around the world, governments and individuals are actively working to return land to Indigenous communities. So thank you again for joining us. Together we'll shape a more resilient and equitable future for CHWs. All right, for today, I'll run through this very briefly. We've got the agenda overview, which I'm providing now, a land acknowledgement that has been provided as well. We'll have a state of the field review by several guest speakers who do quite a bit of work nationally. Carl Rush from Community Resources and Victoria from CHW Center for Research and Evaluation. We'll also get the local landscape in Minnesota, and the most important part is the environmental scan and the results of that work that I'm sure you're all excited to hear. And then we'll go through and actually talk about the tangible next steps in terms of developing that sustainable plan, which will include developing work groups together. And then we'll close out, and we have a special announcement to make near the end. And I think, James, to save on some time here, what I'll just say about this slide is this will be part of the documents that go out at the end of the meeting, but it is important that everyone in the room acknowledge that we do have a definition of what a community health worker is. So it's important to be unified as much as possible if we're planning around the workforce. So remembering what a CHW is as a frontline public health worker who's trusted and has an unusually close relationship with their communities. Next slide, James. And in the state of Minnesota specifically, we do have education requirements for the CHW role. And this is something that is currently written into statute as well. And so it's a credit program through a wide variety of post-secondary institutions. Next slide. This is for those of you who are unfamiliar with community health workers, but are joining. This is kind of a very nice high-level overview of what community health workers do. Many different provider types in the healthcare space and public health and community health space provide these types of services, but these are within the scope of what a community health worker does specifically. Next. And I want to give a quick shout out to the MNCHWA team. There was a lot of work and effort put into everything that we'll be discussing today. So I just wanted to acknowledge, and I think this is our first big team photo in a while with all of our new people. So thank you, everybody. I love you guys. And now I'd like to introduce our next speaker. Carl Rush. Carl has specialized in policy and workforce development for various community health workers since 1996. He's advised on CHW policy initiatives in more than 25 states. He was the lead author on a 2007 HRSA CHW National Workforce Study and co-led the CHW Core Consensus Project, also known as C3. Between 2013 and 2016. He's completed multiple national policy studies with the CDC on CHW certification workforce development strategy. He's a consultant directly to the National Academy for the State Health Policy on their CHW Policy Learning Community TA project, and directly to Envision for their CDC-sponsored TA to state and local governments. He was on the steering committee that eventually became the inaugural board of directors for the National Association of Community Health Workers, and he's been serving as a policy consultant to NASHWA ever since. So, Carl, I'll transition it to you.
Great. Thank you, Anne. Appreciate it. And I appreciate this opportunity to be with you today. There's a lot of exciting stuff going on, a lot to cover. I've been told in 20 minutes this is going to be interesting. But I would say that if there are discussion points or questions you have, and time runs out, please do go ahead and put them in the chat. I will try and respond to questions via chat as the meeting goes on. So I want to touch on a few basic points about where we are nationally. And a big trend, of course, has been state plan amendments for Medicaid. They're now in 19 states. There are at least these 9 states now that are planning or actively working on state plan amendments, and a couple of states in which legislation is pending. Arkansas is moving along. Their bill has passed the state house and is in committee in the Senate. So we're optimistic about that one. So we've had quite a bit of experience since Minnesota pioneered. You were the I don't know, canary in the coal mine. I don't know what what you want to say. Quite a few years ago, and we appreciate and we've all benefited from your experience over the years. There's some persistent issues with state plan amendments. The one is that in a lot of states, it's very difficult for federally qualified health centers to tap into CHW services funding. The number of states have come up with workarounds for that, and we can, time permitting, maybe talk about ways that has been resolved in other states. There are some variation in billing rates. They range anywhere from in the order of 30 something an hour equivalent to 60 something an hour. And we'll come to Medicare, in which case the rates are even higher than that. I think the highest Medicaid rate is currently in New York, which is about, I think, $72. There is a lot of interest in trying to work CHW payment into alternative payment methods. Most of the states, as Minnesota started out doing, use a fee-for-service billing for CHW services, which most people would agree is not a great fit. There are 2 state examples. I'll go back. Alternative payment models. California's introduced a per member per month capitated payment system for federally qualified health centers. It's a voluntary program at this point, but it is attracted a lot of interest. And Maine has a primary care case management system that integrates CHWs into care management. A number of states have really struggled with the integration of community-based organizations into Medicaid. You all have been relatively successful in Minnesota, but some states are still struggling with that, how to make that work, how to enable those CBOs to participate. There is at the same time, and now this has been well over a year since was officially implemented, that Medicare is able to pay for CHW services. There are other types of providers who can offer the same services, but they are emphasizing CHWs. And the implementation of this in almost every state has been slow. There's a lot of uncertainty around it. And so we're trying to gather intelligence about how people are doing with it, and of course I would be very happy to learn more about what your experience has been in Minnesota. But the the crucial point is that there are two categories under Medicare Part B for health-related social needs. The main one that CHWs are going to be billing under, we believe, is community health integration. They're essentially the same services can be offered under either category. The difference between the two of those, and this may be useful shorthand for you to remember, is that the community health integration eligibility depends on the individual having an identified social need, regardless of what their clinical diagnosis is. Conversely, for the principal illness navigation services, the patient eligibility depends on a serious illness or clinical diagnosis and the prognosis for that illness, whether there are social needs present or not. And that's one of the reasons why the CHI category is more attractive, because community health workers can have tremendous impact on the socioeconomic drivers of health. So that's just a quick shorthand for you on that. The basic provisions for Medicare, and I'll do this quickly because I'm sure some of you are quite familiar with it. There's a wide range of activities. The official list of activities looks like a laundry list of what CHWs can do. So it's obviously very well tailored to the work of CHWs, but they are in the Medicare context, they will be considered auxiliary personnel who are providing services that are incident to clinical care. It's a real different sort of relationship from the one in Medicaid. Services under Medicare must be ordered by a billing provider during an initiating visit, and that provider is also responsible for general supervision. The CHW, or I'll come to this, a CBO who is partnering with the billing provider cannot bill Medicare directly. Only one billing provider for a given patient, so this is clearly that provider needs to be someone who has ongoing care responsibility for that patient. That's been one of our cautions at the very beginning. We were hoping that, for example, emergency department providers could order CHW services, but that is not permitted because they don't have ongoing care responsibility. Providers are actively encouraged by Medicare to partner with CBOs, but the CBOs cannot bill directly. That brings us to a really interesting set of issues around people who are dually eligible for Medicare and Medicaid. And this we're trying to sort of track what is happening so far. There's not much solid information out there about what's happening. But one of the concerns about Medicare specifically is that it requires 20% copay for most services, which includes the CHI services. We do know that providers are not willing to, or not permitted, excuse me. Many of them would like to waive that copay requirement, but they are not permitted to do that. For dual eligibles, now the state Medicaid program is technically required to cover those copays, but at least potentially the states could object to that. And we're not seeing much feedback on that yet. There are most Medicare recipients have either a Medicare supplement plan or a Medicare Advantage plan, which generally cover cost sharing. There are Medicare Advantage plans for dual eligibles, and they are widely marketed around the country, and they are able to do this. We don't have good intelligence on what their plans or preferences are in terms of how they would take care of this cost sharing requirement. We and I mentioned, as mentioned in my introduction, I'm working with the National Academy for State Health Policy, and they have been scouring the country trying to get information from the dual eligibles program office in the state Medicaid uh, unit, and we have not been able to find much. And so we would welcome any intelligence that you want to provide to us about how Minnesota is looking at dual eligibles in um, in the context of the new Medicare benefit. There are different relationships, and you all have been used to for now 15, 16 plus years, um, the relationships that are necessary to make things work with Medicaid. The relationships necessary for Medicare reimbursement are different. I'm just going to run through those real quickly. Obviously, major Medicare providers, there are provider groups uh, that many of them have a concentration of Medicare patients. Those are really your main source of connection with billing providers. Hospitals, um, hospital charges are paid out of Part A of Medicare, but hospitals often have affiliated physician groups or physician groups that they own outright. And those groups can be really important partners going forward. So those providers will be responsible for billing, but they are encouraged to partner, as I said, with CBOs as the actual employers. The state Medicaid dual eligible office is going to be a very important relationship, and I would assume you've already begun cultivating that relationship. And any managed care organizations that specialize in dual eligibles, and there are a bunch of different acronyms for those types of managed care organizations. And then, of course, the Medicare in general, the Medicare private insurers, because in the case of Medigap, the Medigap policy will cover most of what Medicare itself does not cover. The Medicare Advantage plans are where you submit claims for people who are covered by Medicare Advantage plans. So all of
Oh,
those relationships are going to be really, really crucial to rolling out or cultivating Medicare as a source of payment. It's important to recognize that in a fee-for-service system, no more than probably about 50 or 60% of CHW's time will be billable due to things that CHWs distinctly do a lot, travel and relationship building in particular. There is a lot of interest in blended or braided funding models, but those can be costly to build and maintain. So there are no simple answers here. There are a number of technical assistance efforts out there, and we don't really have time to talk about those, but we've learned some very important things that relationships, as I said, are really important, that it's crucial that state government agencies among themselves have a shared understanding of CHWs and that the policies of various agencies are coherent so they're not pulling in different directions. And then, of course, important to continue to build the capacity of CHW leadership. A new sort of frontier in this, all of this, has to do with categorical programs. There are a bunch of federal agencies that award categorical grants to the states. Some of those allow some of the money to be used for CHW salaries, some do not. And so the question has been raised among several states. Could they be permitted to allocate a certain percentage of each of these categorical grants to pay for CHW salaries? And can those resources be pooled? I worked with folks in Nevada some time ago where they pooled funds from 4 grant programs to deploy CHWs in rural counties. And it was a really interesting approach to doing that. So those CHWs serve the objectives of all 4 of those programs. So, what can the states do now? What would it require federal action? There was in the last administration, there was a lot of interest. The CDC, in particular, chronic disease folks, became very enthusiastic about this, and there is some uh, possibility that chronic disease can be the leverage to influence the new administration. And then there's a partners coalition of a number of the national organizations that are working together on this stuff. There is some of you, I'm sure, are on the National CHW Policy Working Group each month, which is an open meeting. And lastly, you will be getting these slides, but here are some resources for some things that you might find useful in your exploration of sustainability. And as I said at the outset, I will be around for the rest of the 2 hours and would be happy to respond to questions or comments through the chat.
Thank you so much for that presentation, Carl. Really appreciate it. I would like to now introduce Victoria. Victoria Adewumi is a leading public health practitioner and community health worker dedicated to ensuring all individuals have the opportunity to reach their full potential. As co-executive director and co-principal investigator of the Community Health Workers Center for Research and Evaluation, she drives the development of evidence-based evaluation methods and standardized indicators to strengthen CHW programs nationally and globally, ensuring the workforce's effectiveness and sustainability. Previously, during 11 years with the City of Manchester, New Hampshire, Victoria spearheaded initiatives that demonstrably improved adolescent health outcomes through a community school model. Her work included contributing to the city's first CHW program and direct advocacy that established Manchester's adolescent health dashboard. Her expertise also extends to supporting new American communities through the management and direction of grassroots nonprofit organizations. Victoria's work is very much related to work we're doing here in Minnesota in efforts to expand the CHW models that addresses achievement gaps in different communities. She holds a bachelor's and master's from the University of New Hampshire and a master's in public health from Johns Hopkins University. Take it away, Victoria.
Awesome. And thank you so much, Carl. Thank you so much for that presentation. And it just is really exciting to be here with you all. This feels like a long time coming, a lot of work that you all have been doing together, and also the beginning of something really exciting that is going to remarkably improve health, not just in your own state, but across the country. So really, really thrilled to get to be part of this amazing kickoff meeting. As has been said, my name is Victoria Adewumi. I have the honor of co-directing the Community Health Workers Center for Research and Evaluation with Dr. Noelle Wiggins, who sends her apologies that she can't be here with you all today, but I'll do my best to carry the torch for both of us. I'll go to the next slide, please, James. And in 20 minutes, and I'm going to do my best to stay within the time frame, there are a few things that I'm hoping to accomplish with you all. First and foremost, by the end of our time together, I'm hopeful that you'll have a better, deeper understanding of the purpose and work of the Community Health Workers Center for Research and Evaluation, or you'll hear me say CHW-CRE for short. Next slide. I'm also hopeful that you all are going to learn a little bit more about our flagship product, the CHW Common Indicators, their value, their importance, and their use in strengthening national and also local CHW evaluation efforts. And finally, I'm hopeful that you'll get an opportunity, next slide, to hear our perspective on the current landscape of CHW-focused research and evaluation efforts. So you've heard, next slide, a little bit about me. I'll share a little bit now about the history and origin story of the Community Health Workers Center for Research and Evaluation. And in 2015, a group of allies, ally researchers, and most importantly, community health workers came together in Portland, Oregon, and attempted to define how do community health workers define success. So you all know that there's lots of different bodies and lots of different groups that sort of attempt to establish what success looks like for CHWs, but there's something really unique and special about how CHWs, how we ourselves really articulate our own success. And it's not always and not typically cost savings for institutions. It often looks like, how are my patients, my clients, the folks I work with, do they feel and assess their own well-being as improved after our opportunity to work together? Do I have the chance to receive reflective and supportive supervision? Do I have equitable compensation and benefits in the role that I'm in? And so as this team came together, what emerged was the CHW Common Indicators Project, which many of you may be familiar with. And so we'll talk a little bit more in detail about the indicators, but at this juncture, I'll just say that this was one of the first opportunities, number one, to establish shared measurement across the field. So lots of different programs and lots of different places might be using different constructs to really assess and tell their story of how they're being successful. What we love about the common indicators and really the initial phase of our work as the Center for Research and Evaluation is that the indicators allow programs, big, small, across contexts, rural, urban, to have shared measurement that allows them, again, to be effective in communicating with funders, with other constituents, and really do the quality improvement that we know is essential for programs to continue to be strong and sustain. That was 2015 into 2020. We know that 2020 came with lots of opportunities and also lots of challenges, very similar to the season we currently find ourselves in today. And in 2020 came one of the largest investments in the CHW workforce in the history of our workforce. So $340 million as part of the CDC's COVID response, CHWs for COVID response and resilient communities, and CHW CRE, along with amazing partners and incredible folks like Carl, got to support the CHW workforce, 68 communities, tribes, and sovereign territories that were deploying, training, and supporting CHWs, many for the first time. And ourselves at the CHW Center for Research and Evaluation got to be part of the evaluation teams that were assessing how this program was or was not, really establishing incredible opportunities to close health disparities and achieve community health on a wide scale. So the good news is much of that work was incredibly successful. And for us as an organization, it really allowed a clarification of what's needed and what's useful in the field in terms of research and evaluation as we see it. So next slide. And that led us to our 3 pillars. And so first is promotion of the indicators that you heard me talk a little bit about. Again, how can we really create opportunities for programs, regardless of if you have one person attempting to do evaluation or whether you're part of a large health system that has an entire team? How can we establish specific indicators that allow every program to be able to measure the same things and again, tell their story? Next slide. We also recognized a deep need for CHWs to be capacitated to lead the research and evaluation of their own field, as well as non-CHW researchers and evaluators to be engaged in that work in ways that honor the CHW movement and honor the work that CHWs are doing. So we spent a lot of our time supporting CHWs in research methods and understanding how to conduct evaluation for their own programs to do more than just data collection, which has been traditional for the CHW role. And we also are directly involved in supporting researchers and evaluation in communities using community-based participatory research principles, as well as evaluation that's focused on how communities really identify their own needs and can use shared measurement to define success and hopefully implement solutions to achieve health equity. And my last slide here is leading research and knowledge that really supports the field. So much of what we've been doing, again, as part of the CDC project that you heard me mention and in other spaces, is establishing some of that knowledge, much of which we already know and have, but really trying to connect the dots in terms of implementation. There is so much about effectiveness for CHWs that is very, very clear, and less of it that we actually see tangibly making a difference in communities. And so we help lead that research translation, that implementation, and again, engage meaningfully in communities around how can we bolster, support, and sustain the CHW workforce. So that's a little bit about us. Moving to our next slide, I'd love to spend a little bit of time focusing specifically on promoting the common indicators and why we feel that's important. So next slide, please. We, as I've mentioned, are really looking at the indicators, and there are 12 process and outcome indicators, which I'll share with you in just a moment. But the indicators do three things specifically. First of all, they help ascertain assessed workplace conditions that benefit individual CHWs. Again, CHWs are a proven, effective, clearly, I'm preaching to the choir here, intervention to support health equity, to close health disparities. But what are the ideal conditions that actually allow them to facilitate that process? That's what the indicators are really looking to measure. Next slide. And when we get a little bit more detailed, we're focusing specifically on the intermediate outcomes among the participants in CHW programs first. So we know that CHWs are uniquely placed to achieve specific outcomes. The indicators are measuring those outcomes. And also, we're hopeful and we're engaging in ways that allow those indicators to be assessed regardless of the specific context that a program might find themselves in, as I've mentioned. And last slide, we are also, with the indicators, attempting to understand the policies and practices at the program and the state levels that benefit the workforce. So things like, and I'll go to my next slide, things like CHWs being able to be engaged in policy and systems change, things like CHWs being able to enact all 10 of the core roles, things like CHW's ability to be integrated effectively into teams. These are all places that we really try to hone in on within the indicators. And I'll say for our purposes here that the indicators have been used by community-based organizations, Pathways Community Hubs, state health departments, CHW associations, and we often find that state workforce studies, and again, you all have just completed an environmental scan, congratulations on that front. We really see those opportunities as a great way to be collecting some of these indicators specifically. So again, an opportunity for us to really engage meaningfully in how we're assessing what works for CHW programs. And I know there is never enough time, but more questions on the indicators are so welcome. And I'll invite folks to please put those questions in the chat. So if that's where we have been, and that's the work that we've been doing for much of our time as the CHW Common Indicators Project, and now as the Community Health Workers Center for Research and Evaluation, I'd love to spend just a few minutes talking about sort of CHW evaluation at the national perspective. And I'll go to that next slide, please. And you have just heard a fabulous presentation from Carl. So I will not try to replicate any of that great information, but I will share some of the emergent things that we're seeing at the national level that we do think impact and influence how CHW evaluation and research might shape those things going forward, both again at the national level, but with real implications for the work that's happening on the ground where you all are. So next slide. First and foremost, you heard me talk about statewide workforce surveys. Now, these are things that are happening and our organization has been involved in specifically in Oregon, in Illinois, in New Hampshire. All of these communities and others have really said that how we are understanding, number one, who our workforce is, and specifically what kinds of initiatives might be supportive based on the unique needs of our workforce has been something that we've seen as a common theme over the last 24 months and very much into the beginning of this year. Many of those workforce studies, clearly, based on our involvement, have integrated the indicators, but they've also done a lot more. Many states that we have been working with are looking at certification as a specific mechanism to support their workforce, or looking at other different ways to really bolster the work that's happening. And the statewide workforce survey work has been really instrumental in supporting those efforts in ways that really bring color, character, and understanding, especially to folks who may not be drinking the Kool-Aid like we are, and really demonstrate that this is a workforce that not only is doing extraordinary things, but should be supported. Next slide, please. We also, and again, you heard it from the expert, changes that are happening to Medicaid and Medicare reimbursement policy. And so many of you might be familiar that on Tuesday, the House did pass a resolution a budget reconciliation bill to gut essentially somewhere between $880 billion, more or less, from Medicaid. And we know that that has deep implications to the work that happens for CHWs who might be receiving some form of reimbursement or receiving some part of their ability to continue to do this work from Medicaid and Medicare. That has really, for us doing this work nationally, sort of clarified the fact that while reimbursement is in many places essential for this workforce to be able to continue, it is never able to tell the full story, as you all have just heard. And the other thing that feels really important to say around reimbursement is that oftentimes, again, as you've heard, it's challenging for community-based organizations where the vast majority of CHWs nationally are working to be able to be sustained, because reimbursement and billing is a barrier for many of those organizations. And also the kinds of things that CHWs are being reimbursed to do are typically the things that can be monetized. And so if we're saying that it's really essential for CHWs to be able to play a full range of roles, Medicaid, Medicare reimbursement does pose a challenge in that respect. So again, one part of a larger story, but definitely something that we're being mindful and thoughtful of as we sort of assess with our partners what that's going to look like going forward. Next slide.
Victoria,
And the other thing
we're
that
just about
feels,
out of your time, Victoria. So
oh,
yeah,
can I
sorry,
have
this
one
is
more,
the timekeeper.
2 more
Yes.
seconds?
Yeah,
Two more seconds. I'll just say that when we talk about the introduction of standards, which I know that Carl has lots of things to say about this as well, another thing that feels really key and essential is ensuring that the folks who are establishing standards, which absolutely influence evaluation for our field, are CHW led, right? And so how are we making sure that we're lifting up things like C3 and other entities that are really led by CHWs, and making sure that those initiatives have a long-term understanding and commitment to the CHW field. So I'll stop there. I do unfortunately have to jump to another meeting, but please, if you go to my very, very last slide, just for my contact information, I'd love to be able to get more proximate to the incredible work that you all are doing on the ground, and wish you a fabulous rest of your really great kickoff meeting. Thank you so much.
Thank you, Victoria. There were some questions coming in, but I was able to answer one of them, pointing them to a resource. So we'll try to do our very best without you. And if people do have questions for Victoria, feel free to put them in the chat, and we can pass those along as well if we're not able to answer them real time. I think one question that came up, Victoria, was just around tools related to the common indicators. And so I think I had gotten some messages too personally on that. There was one in the bigger group. So just wondering where those are. I provided a link to the tool. So I didn't know if that's where you wanted people to go, but there's a great link and resource. I don't know if you can talk a little bit about some of those
Absolutely.
resources.
So first of all, amazing job, and absolutely, that's the right link. James, would it be possible to just go back one slide
absolutely.
to my last slide, just because I want folks to have an opportunity, if they're interested, to scan these QR codes. And so the first is actually the guide. I saw a question in the chat about the rationale behind each of the indicators. You all saw sort of a snapshot of the 12 indicators, but this really goes into number one, what each one is, specific content around how you can incorporate them into a survey tool or into other like text language or template language that you could be using. And also my other link is the data analysis guide. So we have a team that would love to continue to work with you all around specific analysis of the indicators, but you don't necessarily need us if you feel confident and competent in being able to do some of the data analysis yourself. This data analysis guide will send you pretty much everything that you need to know if that's your choosing. So again, that first QR code really gives the guide of specific information about each of the indicators and how we recommend you incorporate them into your existing evaluation tools. And the other one gives us the specific analysis guide info. So again, both of those things for your for your consumption at your leisure. And more questions, please put them in the chat. I should be able to stay a couple more minutes.
Perfect, for sure. We've got one from Ann Gainey, actually, and she's asking, is CRE available to help organizations with the CHW outcome evaluation?
Nothing would bring us more joy. So we have, as I mentioned, a specific team, and I'm realizing that my email is not on this slide. So apologies. I will put that in the chat right now. But that we have had the pleasure of doing great work with some of your neighboring states, but I don't know, and Anne will correct me if I'm wrong. I'm not sure that we've had the opportunity to be working locally on the ground with any community-based organizations or other organizations that would like to do this and might want some more hands-on support. And so we would love to be engaged more deeply. And any other questions that you have, we're here. So please feel free to email us, reach out, and we'd love to continue to be a resource.
Perfect. And Carl, it looks like we've got a question for you. Are you able to highlight the Q&A done in the chat? Let me scroll back up so I can read that out there. Is this, Linda, is this in regards to the question on the rescission of guidance on health-related social needs? I think there was some conversation going on in the chat about that. And maybe, Carl, you can speak to that a little bit more. I think you were doing some research.
Yeah. I thought at first this is from Brittany, and I had not seen the guidance that she referred to. I've tracked it down in the few minutes since, and this had thought they were the health-related social needs because my brain was focused on Medicare. That this is actually Medicaid and CHIP. That they're CMS is saying that the guidance on payment for these kinds of needs, services related to these kinds of needs, has been rescinded, and that CMS will consider applications. These appear to be principally applications for 1115 waivers. And before we get, we are going to obviously follow up on this more closely. I've communicated already with some of my national colleagues about it, but it is not closing the door, saying applications will be reviewed on a case-by-case basis, but that it's important for us to keep in mind that in this context, for Medicaid purposes, they're talking mainly about the payments that many states are making for things like food programs and housing and that sort of thing. They're actually using Medicaid funds to pay for those direct services. That is not necessarily the role of CHWs in all of this. Is many times to screen and refer people for such services, but not the payment for CHWs is not considered the provision or meeting those health-related social needs. It is a facilitation role that the CHW plays. And that, at this point, as far as I can tell from this, what we're seeing is not at risk, because the services that meet these needs, these social needs, are not necessarily paid for by Medicaid, that there are other payers and other service providers who actually provide the direct services to meet those needs. So there is going to be a lot of, I think, upheaval over this, because a lot of states have found it very beneficial to cover services like food programs and housing related services and that sort of thing, that ends up reducing the overall total cost of the Medicaid program for the state. And so that is an argument that's going to be had, but I don't see this as an immediate threat at this point. They said there are very few states that are actually using waivers, in fact, to pay for CHW services. Most of them are using state plan amendments. So that's probably more than you ask for, but we are on it and looking at what the implications are going to be going forward. But this announcement just came out today. That Brittany had sent a link to, you can see there in the chat, to a news item about it.
All right, well then let's move this on forward. Anne, I'm going to turn it back over to you because you get to talk about the CHW landscape here in Minnesota now that we've talked about the national picture a little bit.
Yes. And then I will, as part of this group, I mean, a lot of our conversation that we really want to have while we're here is this environmental scan. So I'm going to move maybe at a a slightly kind of faster pace, but feel free, everyone, send me a note, say, hey, and slow down if it's going too quickly. So I'll let you advance those slides, and then I'll introduce our speakers here. So again, I'm Ann with Minnesota Community Health Worker Alliance. I think the vast majority, I was looking on the registration list here, I think the vast majority of everyone knows the work that we do at the Alliance. This is an image that we use a lot at the Alliance, because when we define who we are, we define ourselves as being part of the broader community, embedded in broader community, because we work with stakeholders who are across all different sectors in the state. We're community health workers ourselves, and we engage with community health workers on a regular basis, and not a day goes by where we don't get inquiries from different organizations and sectors, and just folks that want to engage with us and learn more about community health workers, and want to, they're looking for resources, and so we are a statewide nonprofit partnership group, and this is our sort of North Star. It's you all, the work that you do in the community. We don't provide as an organization direct CHW services, and you'll probably see why shortly here in terms of all the other things that we do. We tend to pass along opportunities that we find where people want to hire a lot of CHWs, but we do quite a bit of support and workforce development in this space. Next slide. Yeah, so this is just a really high level overview, but I do want to walk through it, because having a CHW network that is strong and very robust in the state and has a long history is what I would say from a national perspective, what we've seen with trends, that is the foundational element of building a CHW workforce and sustainability. And the reason why it matters, and all of you know this, but a CHW may be no different. Think of a CHW in the light of how nurse practitioners develop their profession over time, or physicians in this country, or many other provider types or groups, right? So you need that representation, you need engagement, from CHWs. And so a CHW network being strong in the state, that is the way that you build the most effective strategies for the CHW workforce in general. And so at the Alliance, we just have a lot of wonderful things happening, and we represent really all of the stakeholders, many on this call. It's the kind of combination of our combined efforts that makes what we do possible. So at the Alliance, we've got the Minnesota Community Health Worker Curriculum and partnerships with the schools through our statewide education committee. We have a structure, as I mentioned earlier, for CHWs in the state. Believe it or not, some states don't have that structure. We know this because we consult with those states occasionally to review their curriculums that are being developed. So it is still a big deal that we have this, and we are considered leaders as a result of that work. We help to define some of those CHW professional standards, like boots on the ground. So Victoria mentioned kind of 10 different roles or kind of areas that CHWs are in, and the Alliance really serves as the boots on the ground. We really have experienced CHWs that we can work with employers to help them define those standards. And so there are a variety of areas where we're providing assistance. We have an apprenticeship program. We have the registry for the state for community health workers. We provide a lot of leadership training. Go to the next slide. This is the reach of CHWs in Minnesota. So with our registry, we have sort of a map. The different colorings just show whether they're newer CHWs or more veteran CHWs. But we are really all over the state, and when it comes to the workforce in terms of the registry that we have at the Alliance. Next slide. So when I think of the landscape, what I wanted to kind of hone in on just a couple of key points. So one, our curriculum that we have right now is in use, active use, either partially or fully in at least 20 other states. that's a really big thing. So if we want to do pioneering work here, there's a really big chance for those of you who kind of have that global mankind perspective, there's a really big chance that it will make an impact at the national level. We have that engagement through, again, our statewide CHW Education Committee, where we work directly with the schools, and we're privileged to do that with the schools on the curriculum itself and make sure there's CHW representation and kind of owning that curriculum, if you will, and guiding what their workforce should be educated on and learning. I talked about the importance of the Alliance as a whole, as a CHW network organization. So we're providing training and supporting hundreds of CHWs annually. Our registry is ever growing. We're trying to increase that so we can work with groups here in Minnesota with Victoria, for example, to do some of these workforce studies that we need to do. We're very active. We've got we're popular. I'd like to say we've got thousands of unique visitors to our website every month. So we're really viewed as that powerful resource and hub, if you will, for all things CHWs. And then, of course, we're doing events and getting better and better at them as we go along. The other thing is, as I mentioned, CHWs as a health profession, it's really important that CHWs themselves are engaged in owning decisions about their workforce. So if you think about a lot of different, again, health professions out there, if we were going to have a meeting talking about scope of physician practice or what sustainability and things like that, it would be crazy not to have physicians in the room. And so, CHWs being in this space, and we've got CHWs on this call, very experienced leaders in the field. That is also unique as a strength, and we've got to make use of that in any kind of sustainable planning for the work. Their perspectives are highly important. I think, well, the last thing I'll say here is just that the relationship that we have in the state locally with our different government entities is just really good. It's a nightmare situation at the national level with other states. We work with different groups, so we need to lean in heavy on some of that work as we dig into the work groups, because we have such great collaboration across all of the different organizations represented here, and we have various state agencies that are championing and supporting CHW work. So I'll leave it at that. I'll let Kristen and Laura introduce themselves to keep it brief. Thank you.
I'm Kristen Godfrey-Walters. I'm the Community Health Worker Initiatives and Community Engagement Director at the Minnesota Department of Health in the Health Promotion and Chronic Disease Division, where our aim is to strengthen and expand the CHW workforce to increase access to care and prevention services, to strengthen the community health worker workforce, and to achieve health equity in underserved populations today. I'm here today with my colleague Laura, and we'll be sharing more about the landscape of the CHW field in Minnesota to set the context for the development of the sustainable plan. So as you've heard, Minnesota has a robust infrastructure in place to support the community health worker profession, and there's been recent state and federal funding mechanisms that have allowed for closer collaboration between MDH and the Alliance, as well as infrastructure and capacity building. And one of the key strengths of the collaboration, as Anne just mentioned, is really that the Alliance brings the engagement and the voice of community health workers to all of the work that we do together, including through the MNSHWA team itself. MDH for many years has had a strong focus on community health workers as a public health workforce, and now has a dedicated community health worker initiatives unit responsible for collaboration and coordination of community health worker initiatives between state and community partners. And that's really across all industries and settings, employers, and communities that community health workers touch across the state. And so that includes all of the community health workers and CHW allies and key stakeholders that are here today. So those are two foundational pieces of the infrastructure in Minnesota. But as you've heard, our state has been a leader in the nation for infrastructure that allows for low barrier to entry, standardized training, ability to bill for services, paths for advancement to CHWs into leadership roles and within health professions. So you've heard Minnesota was the first state to implement the academic credit-based CHW curriculum program. We were the first state to implement the legislative language through Minnesota Medicaid billing through a SPA agreement for CHW services. And right now, I'm aware that we're one of 2 states with Medicaid adoption of the new Medicare CHI codes that Carl was referencing to address health-related social needs. And I guess to note, there are also really strong sources of braided funding mechanisms, which may be especially important during times of uncertainty. And one of the last building blocks of the infrastructure in Minnesota is really around evaluation and measurement. And I think it's the next key building block that we hope to advance. And we'll be talking more about that today. And I think Victoria set that groundwork for some of the work moving forward. Okay, so this highlights only some of the foundational milestones for the CHW profession in Minnesota. There are so many accomplishments, initiatives, grants that we could fit on one timeline. This is just highlighting a few. Starting with back in the early 2000s, the Minnesota CHW scope of practice and certificate program were developed. Medicaid coverage of services was established, and the formalization of the Minnesota CHW Alliance. And that was followed by over a decade of continued growth and expansion of the CHW field. Now, fast forward to 2022, when MDH and the Alliance received a Health Resources Services Administration grant, or HRSA funding, for the CHW training program, and 2023, when state statute was established for workforce capacity building, and then 2024, which brought the expanded coverage of CHW services by Medicare and Minnesota Medicaid. So this is where we are today, and there's so much on the horizon to continue the advancement of the profession and to increase access to CHW services, to reduce health disparities and improve health outcomes in Minnesota. Next slide. Okay, I'll just briefly go into some of the things that were highlighted towards the end of the timeline there, including the work between MDH and the Alliance with the Community Health Worker Training Program. We're now in the 3rd and final year of our HRSA CHW training program grant, and the goal has been to expand the workforce and training of both new CHWs and extend training for existing CHWs. And so in a partnership between MDH, the Alliance as a subgrantee with the CHW certificate schools, the Department of Labor and Industry, and employers, the grant objectives have been to increase the number of CHWs trained through scholarships for the certificate program, development of a registered apprenticeship program for on-the-job training, and then development of free online learning modules for professional development for community health workers. Okay, I don't have time to go into all of the progress and accomplishments of the training program so far, but you can see here, we've highlighted some of those key accomplishments to date. There's been 237 certificate program trainees that have received scholarships, 6 apprentices at 4 apprenticeship sites, and 4 upskilling modules developed with 138 trainees that have taken that so far. The second large body of work in Minnesota is an outcome of the 2023 legislative session, where statute was outlined to support collaboration and coordination between state and community partners, really to develop, refine, and expand the community health worker profession, equip community health workers to address health needs, and to improve health outcomes. The statute also establishes a grant to the Alliance to expand and strengthen the workforce through technical assistance, training and support to both CHWs and employers, and to really advance financing and sustainability. The statute also allows MDH to administer the grant to the Alliance and to provide measurement and evaluation, and to facilitate this collaboration across stakeholders. Okay, so some of the key components of this work include the measurement and evaluation, which started with the 2024 environmental scan of the landscape of CHWs in Minnesota. I believe the last one in our state was in 2016, so it was time to conduct a new one to see the current state. And our next steps include refining the statewide logic model for building and strengthening the infrastructure that was developed in 2022. And then developing this sustainable plan or a roadmap for CHW infrastructure in the state over the next 5 years. So the sustainable plan and logic model include addressing barriers to reimbursement and financial sustainability, advancing best fitting and evidence-based CHW service models for various communities in Minnesota, developing a statewide measurement system to demonstrate impact, and advancing training and workforce development for both CHWs and CHW employer organizations. Okay, well, I gave you a high-level overview of the current collaboration at the state level, and now I'm going to pass it off to my colleague Laura Turek, our MDH Community Health Worker Initiatives evaluator, to share key findings from the environmental scan and to share our current logic model. Laura, I'll hand it off to you.
Thanks, Kristen. And James, you can go to the next slide. Thank you. I'm Laura Turek. I started with Department of Health in June. I'm fairly new to the scene, but I have a lot of experience working in rural health settings with clinics and nonprofit spaces. So I've seen CHWs, I've worked with CHWs, and I'm in awe of what they can accomplish in our community. So it was a joy and an honor to get to work across the state for about 6 months, interviewing people like an investigative journalist on how do you do what you do, where do you do what you do, what helps, what's difficult, what's the story. And so what I'm hopeful is that this document, which is available on our CHWI website from the Department of Health, and the link will be in these slides, and somebody could tuck it in the chat as well. It's pretty dense. It's like 40 pages long. We have a 1-page summary for the shortcut, but there are graphs, there are slides, there are quotes from CHWs in there that are very powerful and telling. So I don't want to have you shy away from digging into that document, because the stories of our community members are in there, and the headlines are what you're going to see in these slides here briefly. So again, it was an honor to get to work with MNCHWA and with the community as we did this. Thanks, Kristen. So the headlines right here, the key findings. And again, this was my first run at this. And the minute I finished it, I found about 4 more things that I wanted to include. So we're going to do an kind of round 2 of this with a little more detail, specifically around tribal health and FQHCs and the homeless population as well. So those are areas that took a little longer to uncover some of the information, but there's some valuable stuff out there that we want to make sure is included. But yeah, reading and listening at the same time. So I'll give you a second to look at these. But the big picture here is that we have a very robust infrastructure in Minnesota, thanks to the hard work of all these folks that are on this call. And there are areas that we can expand and strengthen to help specifically with sustainability. And so the sustainability plan is going to be important, and the measurement is going to be what gets us there. These were some of the numbers. I spoke with 105 people to do key informant interviews from a variety of settings. I talked across 11 settings and was able to get some existing data sets. One specifically was around the number of people with a certificate for CHW across all of the different groups that offer that certificate. And we are able to map that. We'll show you that next. The Department of Labor also offered up, or DEED rather, offered up the estimates for CHWs that are currently employed. And then we're also able to show the number of people who are billing for those services. And that's really the story, is how many certificate holders we have, and all the way down to the very few that are billing for those services. These are the maps. And again, these are in your scan, so you can zoom in closer for that. But the real picture is that the metro area has a good number, but across the state, there are pockets of CHWs, both with a certificate and working. The Northwest and along the South Dakota line is fewer, and just above the metro, but below Duluth, that little area there has a very few as well. So areas that could be grown. This is dense stuff, and that's what took me so long to learn and understand it. But the barriers are very specific, and the facilitators, the things that help things along, are very specific as well. But when you get down to it, it's all about the backdrop of the organization, how prepared they are, how ready they are, how the supervisor is prepared and ready and supported. What all of that looks like makes or breaks the experience for the CHW. And so a single CHW could struggle, no matter how great they are, if the system isn't prepared for them. And some of the common barriers are things around salary, policies, documentation of data, both for the people working in that space, but also for people who want to advocate for those roles. Those are all things that came up regularly across 100 interviews. Internal advocacy tools, reflective practices, support from groups like MNSHWA for technical assistance. Those are all real positive things. These are the links for your the scan itself, and we have it typed out there for you. And Kristen, thank you for putting those in the chat. The scan summary, our page, which has many different options on there for the training and the different links, and then an infographic that you might want to access if you want to quick describe what's going on in Minnesota. Great. So the other piece that I walked into, the next slide, please, was trying to figure out ways that we would collectively move forward once we know where everybody's at. And so ongoing, we want to be able to measure. Ongoing, we want to be able to support. And to do that, we think a collective impact model is kind of where this goes. And so the common agenda, the shared measurement systems, mutually reinforcing activities, trying to stay connected with one another, and then having backbone support organizations like MNSHWA with support from all the groups that can help. So a logic model is, of course, what evaluators love to use, but really it's just a roadmap, keeps getting referenced, but it's how do we get from point A to point B? What does the detail of that look like? And so the goal, of course, is to strengthen, enhance, and grow that infrastructure for CHW work. We have a draft logic model that key stakeholders worked on a couple of years ago. That was coming out of COVID, and things have changed in a lot of different ways. And so this logic model is going to be reviewed with these work groups and updated as a part of this plan development. And try not to laugh. Here it is. It's very detailed, and yet we think there might be a few things missing. And so I'll go one more slide, James. So we tried to pull out what we think the strategies are at this current moment and what the outcomes we're going for. And in between is where the work group magic is going to be needed. We're going to ask folks to narrow in on a few things specific to an area and look through what are the strategies? Are we hitting all those? Are the activities the things we think they should be? What's missing? And then what are we expecting to happen? And does that follow? And we want the input from CHWs who are in the middle of all that work, the supervisors, people who are doing the billing, people who are doing the advocacy at different levels, to really weigh in together and then make sure that we're aligned. And that's where that collective impact stuff can really make a change. And again, there's a link for this that was in your welcome packet, a welcome invitation too. These are the big long-term outcomes. And I think these are things that we hope everybody agrees with. And then also, if we're missing something that you think absolutely should be included, we want to make sure we don't miss anything, because this will be the plan, the roadmap that we're going to encourage folks to follow. So again, reducing disparities, supporting CHWs in the work to feel confident and effective in their work, increasing who is the CHW doing the work with which populations, making sure our high-risk groups are covered by folks that make them feel comfortable. Statewide access for things for effective CHW work, and then ability to track and measure, because what we measure, what matters. And right now, these are the strategies that have been identified: networking, collaboration, strategic planning, continuing education and career development for the CHWs and their supervisors, support evidence-based models, which is a whole nother layer of definition and measurement, assessment and measurement, evaluation in general, and then communication, dissemination, and sustainability. So these are our emails. And let's see, I think I pass it back to Anne.
Oh, and Anne, you're muted. Yeah, so we're ready for another. Yeah, we're ready for another brief Q&A. Forgive me for my camera being off now. I realized that my camera died while we were going through that second part of the presentation. But incredible, a lot of really, really good work. So if anyone has any questions for Anne, Laura, or Kristen, feel free, throw it in the chat or raise your hand. We can let you ask that out loud too. And Anne Gainey, maybe you could let me know how much time we have until we have to move on to the next section.
We have a lot of time, James. We are supposed to move on at 1:35. So
okay, ahead of schedule. Can't I was just asked to move the slides back, so I've got that for you, Angela. And then these slides will all be distributed after the meeting as well. But we've got a question from Callie, which is it possible to look into reducing the number of barriers nonprofit organizations or FQHC face in billing for CHW services?
I can help answer that question, but I didn't know, Kristen, if you want to go first. This leads into the work group stuff, but that's how I was going to answer it.
Yeah, go ahead and I can add. Go ahead.
Okay, great. Yes, this is like the biggest thing that I personally am interested in, all these topics that the scan was just amazing. Laura, thank you so much for all of your work. I know it took a lot. There was lots of like, we need this information. What about this? Who do we talk to about this? This was phenomenal. So just big kudos to you and the team at MDH for pulling all that together as we can use it for a lot of planning. And one of those things that we'll use it for is our work groups. And we will have a special work group on sustainability around financing and billing. And one of our major goals that I have for that group, if that group kind of decides it, is to really look at how we can increase the number of organizations that are billing for services. And so to do that, we do need to streamline, or we need to just make it a lot easier, whether it's an issue of just getting the right information in the right hands, or looking to our experts. You know, we've got other groups on this call, I think even two, CHW Solutions, and just other groups that have been trying to assist and kind of evangelize the different ways that groups can bill for services. And so we will have a dedicated work group that will be charged with coming up with specific recommendations that'll get passed on, I think, and hopefully we'll have different payers participating in that group. So it'll be an interesting work group for sure. Anything to add, Kristen?
No, I think you covered it. I think some of the key themes from the scan are, barriers for FQHCs in billing, or being able to get additional reimbursement beyond their current payment rates, community-based organizations being able to access billing, as well as dental providers as well. So those are all areas that could be included in that piece of the plan.
Awesome. And Carl, I see you've got your hand up. Feel free to ask away.
Yeah, thanks. I'm not sure where this fits. First of all, great work. It's looking very promising. You're off to a really good start. And I wanted to ask where this fits, to what extent you've looked at it. There's, for obvious reasons, a lot of reference to evidence base and that kind of stuff. And one of the things I've been talking about with other states is how we shift the focus a little bit of this evidence base, that it not be entirely CHW-centric. And by that, I mean that Medicaid and other payers have a lot of things on their plate, and it is not the job of any of those payers to sustain CHWs or any other profession. Their job is to pay for services and get people healthy and so forth. And so what seems to be getting traction in some other states is to inquire with Medicaid and to actually do some research on this with Medicaid and other payers in terms of what the persistent issues that they're dealing with, that they're struggling with. And this can often be found. Most states have a Medicaid annual report and things like that you can start with. But to really understand what payers are struggling with in terms of public health and healthcare related results, and then position community health workers as a resource to help them address those issues. Rather than saying CHWs are good, you need to invest in CHWs, is to say that we understand where your pain is and CHWs can help you deal with that. So I just want to drop that in there. Not sure, it's hard to, as you say, read all the detail in this logic model, but to see where that might fit, because it has really enabled us to make some progress in states like Pennsylvania, where I've been working for a couple of years, and really getting the attention of these payers by saying your concerns, your needs are important. Okay, So I just want to drop that in there and see what y'all think about that.
I can offer just around the measurement piece, when we talk about health outcomes and having evidence to show the speed at which a CHW can get through some of the navigation pieces that are holding back successful
Sure.
outcomes. That,
Sure.
you know, that them as they go between the
Yeah.
problem of a health issue and a health successful
Yeah.
outcome. Yeah.
Sure.
I totally see that.
the so what I'm saying is that the conversation may shift a little bit, not looking so much at outcomes, but for example, I found in a bunch of states that Medicaid officials, managed care organizations, even providers are very concerned about the issue of low levels of member engagement in primary care. And they don't know how to fix that. And that's, by studying that kind of issue and understanding what their concerns are, it is a slam dunk to me to show, okay, CHWs can be a really important resource. And this can be a very prominently so in like rural areas or with older populations aging in place, things like that, where the system doesn't know how to make that happen. So it's not an ultimate health outcome, certainly, but it is where their mind is at. Where's their pain? What are they struggling with? And it's not always the ultimate outcomes. It's sometimes stuff that's a little closer to home for them.
Great. We've got another question in the chat. Does Minnesota have a Medicaid annual report?
I am looking that up right now. I don't know the answer to it, but I'm trying to find it. So if anyone can find it faster than me, feel free to put it into the chat.
Should be there. Most states do have them.
Okay, we still have time for other questions. If anyone, I'm not seeing any hands shooting up or anything coming into the chat, but I'll give it a little bit more time. I know it takes some time to write stuff out. Yep, see, there we go. Luz is asking, some of the evidence-based models like Pathway Community Health sustain their payroll/reimbursements between CBOs and Medicare. How can an LPH utilize these models and do its own billing?
Hi, Luz. I think that's a great question. I don't know if you want to come off mute and say more. I know there are some local public health organizations that are involved in similar types of models, but I'm wondering if you mean an LPH participating in like a pathways model, or kind of what you're referencing there. And welcome for anyone else if they have the answer too.
Yeah, thank you. Hi, everyone. Yeah, well, actually, we're looking into the PCH model. We're not enrolling to any of these models, but we're looking into how are we going to bill, because what I understand, pathways or the PCH, they get reimbursement, and then they contract with local community partners. So if a public health wants to adopt this role, how are we going to bill? Are we going to get reimbursed directly from Medicare and other community partners, or does these funds will come through PCH, and then do we have to pay PCH? You know, it's confusing. So we're trying to find out, are we going to do our billing separately, or we have to pay towards the PCH entity? So I don't know, I hope I make sense. But we're trying to learn. We're brainstorming and see what would be good for us, because we would like to, you know, being able to measure outcomes and make sure we're utilizing CHWs appropriately so we can help our communities, you know, serve them and become, help them become more healthier.
Yeah, thanks for that clarification, Luz. I think there's probably a number of different ways that can be structured. It looks like Megan Ellingson has some information in the chat about local public health billing directly CHW codes to DHS or potentially to Medicare. I think kind of the concept of some of those hubs, as far as like, one of like the community health worker pathways hub, is that one organization is deemed as kind of the backbone organization that then, for example, local public health and the other organizations, all of their billing would go through that central organization, and then the dollars get distributed back out to each organization, each CHW organization that's participating. So I think it does get pretty complex, but happy to connect you to others in the state that are doing similar work, because I think there are many options. There's options to work with the backbone organizations. There's options to work directly with the payers, have contracts directly with the payers and bill the payers, as well as DHS directly. And it looks like that's what Megan has in the chat here. But happy to connect, or if others have other resources for Luz, feel free to put them in the chat.
Awesome. And now Susan Ninham has had her hand raised for a little bit, so I want to let Susan, you can feel free to unmute and ask your question. Thanks for your patience with that.
Hello, everybody. So mine are pretty simple questions. One is the current CHW training program that will end in 2026. Is there a proposal that's going to be resubmitted for ongoing training? And second, I just was curious how many individuals from tribal communities are reflected in the survey that was shared. That's it.
Great, thank you, Susan. To answer your first question about our HRSA Community Health Worker Training Program grant, it ends in September of 2025. The grant does, and we plan to continue a semester in fall of 2025 to offer the scholarships, or that's what the hope is, and then that we could continue to spend those funds through that next year for that cohort. There are not options right now for additional funding. HRSA does not have additional funding opportunities right now for those scholarships, but we do hope to do some data reporting and evaluation that would lead to maybe some recommendations as to whether other sources should be sought for scholarships in the future. So we can continue to look into that. And then Laura, I don't know if you want to speak to the inclusion of the tribal communities in the scan and the plan for the next phase of the scan.
Yeah, so we were able to connect with 2 different tribal nations for learning about the community health representative, community health worker crossover, and included that in this version, and then have done some meetings, and I attended the Tribal Health Data Symposium the last 2 days to try to learn a little more before I go to other tribal nations. So I want to make sure I know all of the research before I show up, so I'm not asking them to teach me too much stuff right away. But we have plans to connect with as many as we can to upgrade the next version of the scan to be more inclusive of all of that content as well. Specifically up in one of them, we saw a lot of connections between housing and CHW work reservations. So that was one interesting spot, and then that's included in this scan.
And
thanks for the question.
Susan, I was going to add that for the Alliance, so just because the federal grant, it's not clear if there'll be any continuation or an opportunity to renew or reapply for that funding, doesn't mean that the network within the Minnesota Community Health Worker Alliance isn't looking at ways to sustain some type of CHW scholarship program and training on an ongoing basis. So I know, at least for me in my role, I'm hoping to present a plan to the board as part of our sustainable funding planning to at least have, even if it's a small fraction of the number of scholarships that we were awarding each year at the Alliance, to see if we can retain that and still develop the field that way, because we want to provide access, and there are social barriers and different challenges, and we want to support. It's a key part of expanding and growing the workforce. So I just wanted to give you some hope there, and hopefully give everyone some hope that we do want to do that. It's all hands on deck. So,
Thank you for responding to those questions. I appreciate it.
Perfect. Ann Gainey has just told me that it is time to move on. So thank you for that, Ann. And let's keep things moving. I'm going to turn things over to Angela Fields, who is our Associate Executive Director at MNCHW, to introduce kind of like the next steps with the sustainable plan development. And then we're going to start talking about our work groups as well. So Angela, I'll turn it over to you.
Absolutely. Thank you, James, for that transition. Good afternoon, everyone. Welcome. I'm going to lead this conversation and talk about the development of the sustainable plan and our work group roadmap. The objective is for MNCHW in collaborations with MDH, CHW employers, payers, community stakeholders to create a sustainable plan for CHW infrastructure that would support the diverse needs of communities in Minnesota through the most suitable models that these work groups recommendations. The process of developing the sustainable plan begins right here and right now with this initial kickoff meeting. So we thank you for being a part of this conversation. Followed, there will be focused on work groups. And those work group creations will be from March to April 2025. These work groups will review and refine the logic model that we saw in Laura's presentation and provide clear next steps and recommendations for the goals, the objectives, and the activities of the sustainability plan. The focus will be on specific aspects of the CHW workforce model with an emphasis on the health, equity, inclusiveness, and responsiveness to community needs. The purpose of the work groups is to review, as I said, and refine the logic model for building and strengthening the CHW infrastructure in Minnesota, ensuring that the CHW workforce is sustainable, equitable, and responsive to community needs. The groups will collaboratively develop next steps and recommendations to support the implementation of the sustainable CHW workforce model with an emphasis on health, equity, and inclusion. These work groups will particularly focus on evidence-based and team-based care that align and alignment with health equity outcomes. Next slide, James.
And I can go one further. We have a little introductory slide ahead of each individual work group, but Angela, here's yours. Sorry about that.
Oh, no worries about that. Thank you for that transition. And I'll talk to you about our community engagement and equity and health equity outcomes in evidence-based models work group. The purpose of the work group is to review and refine the logic model for building and strengthening the CHW infrastructure in Minnesota. The group will also focus on the purpose to ensure that the CHW workforce is sustainable, equitable, and responsive to community needs. The focus, there will be a focus on evidence-based models of community-based care to improve health equity outcomes, to develop actionable next steps and recommendations for implementing a sustainable CHW workforce model in Minnesota. Next slide, please. The community engagement and health equity outcomes and evidence-based work group. The objectives of this work group will be to review and refine the logic model for building and strengthening the CHW infrastructure in Minnesota, ensure that the CHW workforce is sustainable, equitable, and responsive to community needs. The focus will be on evidence-based models of team-based care to improve health equity outcomes, and to develop actionable next steps and recommendations for implementing a sustainable CHW work group model in Minnesota. The work group leads will be myself as a MNCHW lead, and also I will be co-leading this work group with the MDH lead, Kristen Godfrey Walters. Next slide. I'll talk with you through the data and evaluation growth work group. It will be led by Laura Tarp, Minnesota Department of Health, as well as our MNCHW lead will be Rachel Stoll, who's not present for this section of the meeting today. Next slide.
Yep, and then Laura said that she would be able to present on this
Sure.
one, so we'll turn that over to her.
Absolutely.
Sure. Thanks, Angela. The purpose of this group, very similar, is to refine and review the logic model strategies, make sure that the objectives and activities make sense and follow the flow to get us where we want to go. this will be a heavily focused on metrics, and so assessment and evaluation. So some of what we heard today from Victoria, the indicators will be a big part of what we'll probably discuss. And we want to talk a lot about health outcomes and effectiveness and other indicators that we could use to show sustainability. The people who should attend, we would really encourage CHWs who are interested in data and evaluation to join this group. Program managers, especially those who use data to show dashboards or presentations to leadership to advocate for CHWs and their abilities. And then state agency reps, of course, with experience with data dashboards, evaluation metrics, and any other data sets that are existing previously and ongoing. And then, of course, any CHW data experts in the community who would have any thoughts about how this could be set up in an effective way. Next slide. Thank you.
Thanks, Laura. We can turn it over to Van Yi, who's going to talk about training and workforce development work group.
Hello, everyone. Thanks, everyone, for being here. I will be leading the training and workforce development group. James, you can move on to the next slide. We also have Shandy at the Alliance, Shandy Potis-Mongra. She will be co-facilitating those work groups with me. She is our new workforce development coordinator. The purpose of the training and workforce development group is to review and refine the logic model strategies, objectives, and activities related to training, continuing education, and career development. And we will also be discussing how to provide clear next steps for implementation of those components, referring to the logic model as well as to the environmental scan for documentation of a sustainable plan as well. So you heard a lot about the logic model earlier in others' presentations. We'll be referring to that to answer questions related to increasing the number of CHWs, increasing the number of apprenticeship sites and upskilling training opportunities, career growth in field, and supervisor skills. Next slide. So we are interested in hearing from, of course, our CHWs, nothing about us without us. We're very interested also in the voice of those on our education committee, folks from chronic disease specific stakeholder organizations, and then the Department of Labor and Industry, whom we are working very closely with already on the apprenticeship program. And then, of course, employers of CHWs are those who plan to or have the desire to employ CHWs in the future. Again, we'll be referencing the environmental scan and the logic model around strengths and needs and continuing education and career development, communication, dissemination, and sustainability. And then also, what are the existing needs and opportunities for CHW career pathways, apprenticeship, so that's structured on the job training, and then employer organizational readiness as well.
Perfect. Thank you, Van Yi, and I'll turn this over to Ann Gainey to talk about the Sustainable Funding and Policy Work Group.
Thanks, James. You can go on to the next slide, please. I would say last but not least comes our Sustainable Funding and Policy Work Group. This group is going to be looking at some of the very questions that came up in our meeting today. We will be reviewing the logic model strategies and objectives around financing and payment, because we want to make sure that CHWs are adequately funded and sustained. So we're going to look at both public and private sector financing, and then alternative models as well. And then our second purpose is to provide clear next steps for implementing the logic model. And within that, working with community-based organizations and making sure that community-based organizations can access some of these public and private funding models as well. So our objectives are to increase the number of employers billing for CHW services and to develop strategies to support community-based organizations, including FQHCs, to receive payment. So those are directly from the logic model. People we'd like to see on this include, of course, people working within payment systems, people working within some of the larger statewide organizations and community-based organizations, CHWs who have some interest in payment models and funding, and just CHWs in general. We want, as Van Yi said, nothing about us without us. We want that CHW voice in every one of our work groups. And so we will be looking for people to work in this work group and all of the other ones. And Sam put a link in the chat where you can sign up to be on one of these work groups. So those are our 4 work groups, and I'm going to turn this back to Angela.
Thank you, Anne. And now we will open it up for a brief Q&A section. Are there any questions that you would like to know more about the work groups or anything content that has been shared here with you today? Please feel free to come off mute or pop those questions or feedback in the chat.
Chelsea, I see your hand raised. Feel free to go ahead and ask.
Thank you. Just had a quick question. I know one of the challenges in the CHW workforce across the state has been the number of employment or the employment availability. So just the number of positions available for CHWs. And I didn't see anything addressing that specifically. Increasing the number of CHWs across the state, but I didn't see anything about either employment education employer education, or trying to increase the number of available CHW positions. So I was curious as to that aspect. Is that, like the next step, or where does that fit in?
So the Alliance is still doing the apprenticeship programs and doing outreach for that, but we also changed the program for apprenticeship. We have some upcoming work that we're doing right now to put in place for apprentices, but as well as for employers to become a registered apprenticeship site and not have to be responsible for providing all of the trainings. The Alliance would take on that training aspect. Many folks here in this meeting have spoke with me about apprenticeship, and for one reason or another, perhaps having your own registered apprenticeship site has not been a fit for many employers here across the state of Minnesota. So we've changed the trajectory a little bit about as to how that is going to be provided to CHWs. And so that in and of itself will create job opportunities for CHWs.
Thanks, Bonnie.
Yeah, that's a great question. Chelsea, I periodically, I'm curious because I try to track how much CHW job postings say the pay is in Minnesota. And so taking a look at that, it leads me to kind of look and, there are lots of positions that get posted. I think a lot of employers probably also have an issue with retention where CHWs don't stay very long, or they leave due to pay, or so it's kind of a weird situation, right? And then there's of course also that sustainable funding, right? We hear all the time, like, we need money to be able to hire a CHW. And so it's this sort of trifecta of, well, there are positions out there, are those really kind of well-seasoned CHW supporting programs, right, that are good spaces? Are these positions that are posted paying well enough? And, what positions aren't being posted because people, they just don't have the money, or they're waiting for a grant and don't know about billing or how to build those partnerships with provider groups. So.
Awesome. We've got a question from Andrea Hickel in the chat. When the chat is moving, I have to scroll back up and grab that. Andrea is wondering if we can comment on how the CHWI leadership steering team might interface or communicate with the work groups. I'm sure other people have answers. Mine would be invite them to participate in the work groups. Maybe I'm overstepping on that, but the more people involved, the more voices we have. I feel like that's the most effective way to interface, is just by actually being involved. But I'll stop talking.
Thanks, James. I think you nailed it. Andrea, I think, is this question related to the MDH internal steering team that we have? If it is, yes, we welcome anyone who is interested to participate in the work groups themselves. And then, we have been sharing information with the steering team about these processes and the work groups, and we could build that into those meetings as well. But open to other ideas. If you have other ideas on how we should be doing that, please let me know.
I will say, just to address Chelsea, I think other eyes, just like you're describing, is why we want to do this activity. So go through that logic model and see where the things you're thinking about might fit. And if they're not there, that's even more helpful. So like, let's figure out where they should be, or if we need to add a strategy to be successful to get to our outcomes. So just take a peek at it. I think it's pretty dense, but you'll enjoy it.
Okay, any other questions coming through? Because otherwise, I think we could move on to our just kind of wrap up that Anne's going to lead us in. But obviously, I don't want to step on any toes if people are writing or, figuring out the phrasing of their questions. Okay, Anne, I think we can move on to the wrap up here then.
Yeah. So for next steps, I know Angela kind of provided that overview of the purpose of the groups. There was a link that was posted. The Alliance is going to send out we'll probably publish, I think, James, the recording maybe on YouTube.
That's correct.
That it's available. And so we'll send out those notes as well in terms of specific next steps. We want people to join these work groups in the definitions, and so that'll go out probably in a special notice to all of or email message or through MailChimp, through all of our everyone who registered, including those who weren't able to be here. We'll send out that so everyone will get that link and reminder to join a work group. We'll also we're going to post it. If people have questions about the specific work groups in the work, I'd encourage you to potentially sign up for the one that you're most interested in. I don't think we have any rules about signing up for more than one work group. If you're interested, I know we've got an aggressive timeline to pull this all together so that we can come back as a group to discuss the results of the work groups and make those recommendations for the logic model and the plan by the end of the fiscal year with the state. So I think that is mainly it that I had for next steps. Am I missing anything, team?
Just an announcement.
Yes, yep. I was gonna wrap that up. Yeah, I think we only have 4 minutes left. Laura, Kristen, did you have anything that you wanted to discuss in terms of next steps, or Angela, did I miss anything related to the work groups, lasting messages, or James?
Sign up, encourage and sign up. We hope to see you across those groups. Thank you everyone for being here.
Yeah, a lot of work to do. Laura, Kristen?
Nothing else on my end. Thank you.
Just
Yes.
gratitude for folks that participated in the scan and folks who are going to participate in the work groups.
Yes, thank you. This is exciting. Thank you everyone who participated. You can go ahead, James, to the next slide. We did a key part of our work at the Alliance as part of this logic model and planning is the demonstration grants. And this is something that we have through our partnership with the Minnesota Department of Health. And so we released a RFP for our first round of grants for the CHW Capacity Building Demonstration Grant Program. The organization, or we received more than 1.4 million in requests, and we were only able to provide up to 300,000 in funding. We had an external review committee take a look at everything and make those recommendations. And so those were accepted, and we wanted to actually announce the organizations that we're looking forward to working with and learning from. They're listed there: WellShare, Winona Community Hub, the Red Lake Band, and Essentia. All of these organizations have some ongoing amazing work already happening with community health workers, and they've been engaged with the Alliance through in our kind of broader network of partners, community partners. And so the review committee, I thought that these are some of the models to look at. So we're really, really excited. And this will help us document different effective models in Minnesota and go in depth and learn from them, along with providing them with financial support to continue to grow and expand and support their work. So thank you everyone who is going to be involved in this project. I know a lot of us on this call will be partnering and interfacing in some way around this. So thank you. And I think we're ready to bring it to a close. Thank you, everyone who joined. I know we're right at the very end, but there's still enough of us on here that I'm dragging it out to the last second. No, I won't do that. Thank you so much. This was an amazing event. A lot of work to do. We will be hounding you all to participate in this group. If you have any questions, I give you the link here, info@menstrualliance.org, just because we do get a lot of inquiries. So this helps us to filter like who we should send requests to. So reach out to us. There's no question too small or too big to ask of us going forward. Congratulations to those organizations, and congratulations, Minnesota. This is exciting. If I were in any other state, I can assure you I would not have the same level of excitement. We have a really nice foundation with just what we have, the different organizations, our state health department, other state agencies, other community groups, and CHW allies and CHWs. We just have some amazing CHWs. So thank you, everyone, and we will see you soon.